So a few housekeeping items. Please do include your name under your video so we know who all is with us this morning. Please remember to mute yourself during the presentation to avoid echoes and background noise. We will be sure, one of the reasons we want you to take care of that before us is because we want to keep this an interactive conversation. You may want to consider changing your view to the presenter view so you can see the person speaking along with the slides. And we will have the presentation available both as slides and as a recording. So with that being said, we are recording this presentation this morning. So with that, I want to welcome Dr. Helena Laroche. Helena is the new Scientific Medical Director at the Center for Children's Healthy Lifestyles and Nutrition. So for those of you who don't know, the center is a joint center between the University of Kansas Medical Center and Children's Mercy Hospital. We're really pleased to have her join the team at the center. I'm going to read her very impressive bio as she's getting her presentation pulled up. Dr. Laroche is a combined internal medicine pediatric physician who focuses on weight management. She's a scientific medical director of the Center for Children's Healthy Lifestyles and Nutrition, and an associate professor at the University of Missouri, Kansas City. She was a sociology major at Brown University. She attended medical school at the University of Missouri, Columbia. She did a combined internal medicine and pediatric residency at the University of Rochester in New York, and was a Robert Wood Johnson clinical scholar, did a research fellowship at the University of Michigan. She spent the last 13 years at the University of Iowa. Her research focuses on community and family approaches to obesity prevention. She works in partnership with community-based organizations to design interventions for families. These interventions support healthy behaviors while also addressing the social needs and circumstances that influence those behaviors. She's also working with other weight management physicians at the center on research to improve weight management treatment for children. So we're very pleased she agreed to join us this morning and share her background and experience with us related to community and family health promotion. So with that, I'm going to turn it over to you, Dr. Laroche. You're on mute.
Sorry about that. Lovely technology. Anyway, thanks for that lovely introduction, Shelley, and thanks to weighing in for inviting me today, and for all of you for getting up this morning and joining us. So as she said, I am the new scientific medical director, but when I'm not doing that, one of my real passions is community research and working on health promotion with families and communities. So I wanted to tell you a little bit about that today. And I wanted to let you know that it is fine to interrupt me. That doesn't faze me at all. And I'd rather you get your questions answered. And why am I not? There we go. Okay, so to tell you just a little bit about me, yes, I was born and raised in St. Louis and then went to high school in Columbia. So I am a Missourian through and through. As she said, I've been all over. I've been to a lot of different places in the country, but I always seem to keep coming back to Missouri. And particularly, I seem to be working my way along the I-70 corridor. So finally, I made it to Kansas City. So we're going to talk a little bit, we're going to do a little bit of background. We're going to talk a little bit, I wanted to let you know a little bit about the different types of research that I do. We're going to talk specifically about living well together. And then if we have a little time, we might talk about another project on food pantries and COVID. And then I'd like to spend some time with some discussion and questions. So what are we trying to do? What's most important to me, and you will notice that the word obesity is not on this particular slide, is that what we're trying to prevent is we want people to be healthy. So this is what we're trying to prevent. We're trying to prevent liver disease. We know that 30% of children aged 9 to 17 with significantly increased body mass index have liver disease. We also know that diabetes is on the increase in children, about 4.8% every year in the increase in the type 2 diabetes. We also know that 1 out of every 30 children aged 12 to 19 actually has high blood pressure. And that among children with a significantly increased body mass index, or an increased weight over height, okay, that a lot of them, up to 45 to 60% of them, can have what's called obstructive sleep apnea. And that means that they wake up again and again and again all night long because they're snoring and they stop breathing. And these are very tired children when they get up. And you can see here, so there are 2 types of diabetes, and type 1 is an immune problem that's been going on for a long time. But type 2 is a separate thing, and it's what we see in adults. And it is continuing to increase in children, and that's something we used to call it adult onset diabetes because we didn't see it in children, and now we see it way too much. And the other thing is that the burden of disease isn't fair. You can see on this chart over here on type 2 diabetes that African Americans and Native Americans are bearing a much higher portion of this burden of diabetes. And these are children. So here is my slide about obesity prevalence. And the reason it is on here is because we know that increased weight is linked to some of these diseases. But the point of the matter is that what we're trying to prevent is that. What we want is healthy kids. We're not worried about what exact shape they are. Okay, but we see that 17% of our children have significantly increased weight for height, and that it's even higher among WIC participants. So when we think about health in children, this is a model that I like to look at. And what you can see in the center is the parents, right? And what do parents do? They model healthy behaviors. They impart their knowledge and beliefs about behaviors to their children. They control, at least within the home, the accessibility of healthy and unhealthy eating options, physical activity options, and they shape their children's behaviors. You know, we reward, we punish, we incentivize things as parents. But around these parents are all these other things that are making a difference, right? There's media and policies. So there's nutrition labeling. There's schools. Do their schools have PE or not? What are the food policies in school? There are companies that are advertising directly to our children all sorts of junk, right? And around them are the community characteristics. Are their neighborhoods walkable? What are the crime levels like? You know, do they have access to healthy foods and recreational spaces for themselves and their families? And then what are those organizational characteristics around them? You know, what's the school environment like? What's their job environment like? What are the demands on them? Are they working nights and their kids are gone during the day? Are they ships passing in the night? What, you know, all these other things affect their ability to parent. So if we think about what are the determinants of health, there are a lot of things that determine health. But when we think about some of the things that we know that affect a lot of these diseases that I was talking about are things like sleep. We don't think about that, but lack of sleep affects your health. It affects your eating. It affects your ability to be physically active. It affects your stress levels. Physical activity is really important, as Weighing In has been working on very hard recently. And stress is important. When you have a lot of stress, it has effects on your body, and those effects can lead to disease. Diet is very important. And then there are things like medications that doctors like me prescribe that make people gain weight or change or affect what they can do. And then there are all sorts of other things that we're still understanding. There might be chemicals that people are exposed to. There are actually things like the bugs in your gut, right? The bacteria that live in your gut can get changed by your environment, and we need those bacteria, and they affect our health. So it's very complicated. It's not this simple idea that just eat right, and move, and that's going to fix everything. It's a very complicated thing. So I just wanted to give you guys a little bit of an idea of the different sorts of research that I do and have done. Okay, I've focused a lot on family interactions and interventions, looking specifically at things like diet and physical activity and sleep, and starting out with a lot of interviews with families. I started out as a fellow sitting in the homes of lovely families who allowed me to talk to them about what was going on in their families regarding diet and physical activity, and working all the way up to doing interventions like the one we'll talk about today, Living Well Together. But I've also done some other things, talking about what we call the microenvironment, all the different environments that kids come in contact with. So I've done a little bit of craziness with concession stands. I've worked in college cafeterias. We'll talk a little bit. I've been about work with the food banks. And then I've done some work with the Prevention Research Center in Iowa, doing community level physical activity interventions in small towns. And then I also do work with adult and child weight management research. So here you can see, here's some of our posters when we were doing concession stands, and here are some of the fruit bowls that we put out in the college cafeterias. So this is my goal. My goal is to put myself out of business. So, if junk food's out and healthy food is in, what's going to happen to the doctors, right? We'll do something else. So this kind of leads me to the idea of family-based prevention, so that, we know that treating disease once it happens is hard, actually. And so I really want to focus on prevention so that nobody ever gets to that point where they need treatment. But when we talk about children, a lot of the trials have been school-based, and rightly so, because that's where the kids are concentrated. But families really have an important influence on child behavior. And in fact, we always think about adults influencing kids. Well, kids also influence adult behavior, and any of you who are parents out there know that. So really focusing on family-based interventions really can hold promise for promoting healthy lifestyles and preventing illness. But we also know that community environment can influence family health, and that access or lack of access to healthy foods, physical activity opportunities, and basic resources such as housing, heating, can really affect people's health. And that the idea was that providing resources, helping people connect to some of those basic resources and to those opportunities for healthy food and physical activity, might help families be able to make healthy choices and be able to be healthier. And then that it was especially important for low-income families who are struggling with few resources. But there really wasn't a lot of work combining those two ideas, combining family approaches and community approaches. So that's really what we tried to do. And so that's where Living Well Together comes in. This was a community partnership, an academic community partnership, combining a lot of different organizations, including Primary Healthcare, which was a community health center in Des Moines, the Des Moines Area Religious Council, which was a religious organization that provides food. It's a food bank, so it provides food to food pantries all over the city, and in fact runs some of them. The Des Moines Area Community College, which was a community college that does workforce training for adults. And then the ISU Extension, who does nutrition classes. They're very much like the extension people you're used to here in Missouri. And then the Evelyn K. Davis Center for Working Families, which was a unique organization that really brought together nonprofits from throughout Des Moines to help connect families with services. And then the YMCA. And I've been working with this group for quite a while now. And so we started out with family interviews with parents and children to understand what was going on, what did they need, how could we help them. And then we moved on and did a pilot study with 45 families just to see if we could pull this craziness off. And we did show that we could at least feasibly and acceptably do this, and that families thought that this was an okay thing to do. So then we were able to get money from the National Institute of Health and to do a really large trial. And again, it was a community-based participatory research, which means that my community partners worked with me the entire time, and we worked on and designed this together and worked on this together. And it was a randomized controlled trial, which means that we actually randomized families to end up in one group or another group to see which was better. And it was a family-based intervention idea to promote healthy behaviors and to prevent excess weight gain in parents and children. And we focused on low-income families where one parent had a BMI of 30 or above. So again, that's that body mass index, which is really your weight over your height. And then they had to have at least one child aged 6 to 12 years of age in the home. And we did this intervention in both English and in Spanish. So where do we find our families? Because we did not do an income test on people. You must have an income of blank to join our intervention. What we did was try to find families with lower resources. So where did we go? We went to required meetings for unemployment. We went to meetings for temporary assistance for needy families and for reemployment services. We went there, we set up our table, and we gave a presentation and let people know what we were up to. We went to the food pantries. We went to any family event targeting low-income families. We went to the community health center. We went to our other community partners also recruited for us, and we put flyers and backpacks in low-income schools. So what did our intervention look like? So we divided people into two groups randomly. Okay, and both groups got got community resource mobilization to assist them with basic needs like housing and heating. And I'll talk a little bit more about how we did that. And both groups got written education at the beginning and then quarterly newsletters about physical activity and ideas for different recipes and things to do with families. Okay. And then the intervention group also got health coaching. And we had sent our health coaches to the home, and they did use what's called motivational interviewing to work with the entire family on healthy lifestyle goals. And then in addition to that, we helped connect them with diet and physical activity specific resources that were linked to their goals. And we randomized families. They were, like a flip of a coin. They were randomized to one group or the other, but they were stratified by race, ethnicity, and recruitment location so that we had a little better distribution. So each of families in both of our groups met with a community resource specialist, and she sat down with them with a family representative at baseline at 6 months, and she went through a sheet very much like what you see here. Do you need help with food? Do you need help with employment? Do you need help with housing? And based on those needs, she made referrals to community organizations that could help with that. And she would give them a specific name of who to talk to and a specific number to call. And then she would follow up by phone with them in a few weeks to see how that went and did they need more help in accessing those services. And then both groups also got educational materials, and you can see one of our newsletters. All of our newsletters always included a raffle to get people to help us make sure we kept their addresses up to date. And then the intervention group had health coaching, and we used motivational interviewing, and they contacted with the health coach 11 times. So they had 6 home visits, and 5 phone calls, and then as needed in between. And we did send our health coaches to the home to try and get rid of transportation difficulties and to make sure that we can meet with the whole family in one location. So we would meet with as many family members as possible. We did include children 6 and over. There were creative ways of doing that. And we then linked them with resources based on their family goals and related needs. So what is motivational interviewing? Okay, so motivational interviewing is what we consider an evidence-based communication approach. It's a way of talking to people. And it's designed to help people really identify why they might want to make changes, help them think about what are goals they want to change that fit with their values and motivations, not my values and motivations, and to really help increase their self-efficacy or their belief that they can make these changes. The idea is to put the person you're working with in the driver's seat instead of yourself. And then in addition, we tried to get them connected with things in the community. And the intervention group was connected with 6 months of free fruits and vegetables weekly through the food pantry. So they would have to go, whatever their closest food pantry was, we would arrange to have these bundles there where they could pick them up. And there was a 4-month free trial at the YMCA that we could get them connected with, as well as other resources in the community, things like parks and recreation. And so what were the outcomes that we were looking at? Remember, this was a trial for the National Institute of Health, so they want certain things. So we did measure adult body mass index, which is weight divided by height squared, but we measured that on the adults, and we did measure that on the children as well, but that wasn't one of our primary outcomes for kids. We looked at the Family Nutrition and Physical Activity Scale, which was designed at Iowa State University. And what it is a list of 20 questions that are behaviors that we know are related to childhood obesity. And then we looked at what's called moderate to vigorous physical activity, which is kind of one step above walking. Okay, it includes running as well. And then sedentary time, how much time were people sitting? And we did that by using what's called an accelerometer. And you can see a picture of it here. And these particularly looked like out-of-date watches. But they wore them 24 hours a day for 7 days, both one adult in the household and one of the children. And then we were able to use that data to let us know what they were doing. Then we analyzed everything. For those of you who are interested, we did standardize our data to 24-hour a day. We did what's called an attention to treat analysis. And what that means is that if whatever group you started in, you were analyzed in. So even if 1 month later you stopped doing your health coaching, you were still in the health coaching group. Okay. And for those of you who like stats, we used some multiple imputation to account for missing data, but we had 6-month data as well to help us fill that in. And we used a t-test between the groups. So this is what it looked like when it came down. So we assessed 690 families for eligibility, and 454 most of them just didn't meet the inclusion criteria, or some of them decided they didn't want to participate. The number one reason for not meeting the inclusion criteria is that they had children, but they weren't in the right age range. So we needed a child between 6 and 12. And then we did baseline on 236 of them. And then we randomized 208. And we specifically did not randomize families until we knew we could contact them again, because we had learned from the pilot that sometimes people do the baseline and then kind of disappear. And that's exactly what happened with 28 of our families. So they never got randomized. And so then we ended up with 103 in the group that got health coaching and 105 in the group that did not get health coaching. And at the end of the day, when we finally get down to the bottom, at 12 months, we still had 69 of our families in the health coaching group and 74 of our families in the education only group. These are the demographics of our adult participants. So you can see that we were about a third African American, a little under a third Latino. You can see that 95% of the adults were female. It doesn't mean that the men in the household weren't taking part in the project. It just meant that they had not identified themselves as the primary adult to be monitored. You can also see that about 25% of our population had not completed high school. We had some small numbers of people with diabetes and pre-diabetes. That was not an exclusion criteria unless they were on high doses of insulin. The average age was about 35 for the adults, and our average family size was 4, but we went anywhere from 3 to I think we had a family maybe of 7 or 8, maybe even 9. The average family income for the whole family was about $28,000. And the average BMI of the adult was 39, which is high because remember, they had to be above 30 to be in the project. What did our kids look like? They reflected the adults, though we were half and half men, boys and girls. Their average age was about 8. Now this is the child that we took predominantly the measurements on. There were kids of all ages, brothers and sisters in the home as well. Their average BMI percentile was about 77%, and that would be in the normal range. But we had kids everywhere from the normal range to kids who were carrying extra weight. Okay. So if we look at their activity at baseline, and these are just the mothers and the children, there were very few fathers, and so they have been dropped out of this particular graph. But we can see that if you look at the parents, they are averaging about 100 minutes of moderate to vigorous physical activity a day. That's actually really good. And if you think about that, if you drill down and look at some other information that we have, what you find out is that 1, most of this is being done at work, and 2, it's because a lot of our people who were in this trial had jobs that required a lot of physical labor, such as cleaning houses or working in certain types of factories. If you look at the kids, you'll see that the girls were averaging a little under an hour, and the boys were averaging a little over an hour. And so the recommendation is an hour a day. So they were getting close. But we would really like them to do a lot more than that. So when we look at our intervention group, what you'll see is about 45 of our group of 103 of them actually managed to contact the health coach 9 to 11 or more times. But then you can see we have some down here who only, who only contact the health coach less than 4 times. So what kind of resources did our families need when we did that baseline resource screening for people?
Helena?
Yeah.
This is me interrupting because I think you had a great point on the previous slide. I wanted to ask something about that.
Yep.
You have resource specialist 199 times.
No, 199 of our families managed to meet with a resource specialist. So there were 9 of them.
One time.
Yeah, one time at least.
Got it.
So there were 9 of them who never did a full screen.
Excellent, thank you.
And then, so when we asked them, the resources that the families were already accessing before we met with them, you can see that a lot of them were connected with free and reduced lunch. A lot of them were connected with food stamps. And some of them had WIC and FIP, which is the TANF version for Iowa. And then if you see here, you can see where we referred them. So we actually had an average of 3.8 referrals per family. A lot of referrals for food help, a lot of referrals for employment, a lot of housing referrals, a lot of referrals for some referrals for family care, health care, and then a wide range of other random things, including some things like a discount card for Parks and Recreation. So this is a very complicated slide. So let me just show you the basics of what this means. These are all the different outcomes that we looked at, the major ones and the this kind of secondary ones. And the first thing I want you to notice is this p-value, okay? And what this is it tells us whether there is a difference between the intervention and the control group in their change in these things. And what you will see is that what you want is a p-value of less than 0.5. And I don't know where my little thing went. There we go. But what you can see is none of them are less than 0.5. And what that tells us is that there's no difference between the two groups, okay? So then what you do see here is these are change in that outcome between baseline and 12 months. So if you look here, you'll see if we look at adult body mass index, or that weight over height, you'll see that basically the adults in both groups, that's not a significant change at all. Their weights just kind of held. If we look at what's that physical nutrition and physical activity score, what you'll see is you'll see improvements, significant improvement in both groups. So there's no difference between the two groups, but both groups show improvement. Then if you look at how much time people spend sitting, their sedentary activity, you'll see that you got that there's a little bit maybe of improvement in the adults, but it's not significant in either group, okay? And you'll see that there is significant change going the wrong direction in the kids. And unfortunately, this is what we often see when you add another year of age to kids, is that the older they get, the more they sit. And unfortunately, we were not able to change that in these groups. And you see the same thing with their more active activity, the moderate to vigorous physical activities, that it went down in both the kids groups. Again, the same. What you'll see here is that the kids, this is their weight for height for their age and sex. And what you'll see is that they basically held steady, and which is good when you're doing prevention, because that's what you want them to do. And then you'll see that both among the kids and among the adults, we got improvements in how much sugar sweetened beverages or sodas they are drinking. And then if we look at it another way, because the complicated thing with this is that when we ask families to make changes, different families chose different changes. So if you just look at how many people walked more, you don't get enough to see a difference, because only a certain number of them decided to walk more, and some of these other ones decided to eat less fast food. So that's why we use the Family Nutrition and Physical Activity Scale to look for change. And this is another way of doing that allows us to use those fancy monitors that we put on their wrists. And when we make a composite outcome, or we give people points, so we give an adult a point for having increased their moderate to vigorous physical activity for 20 minutes, or we gave them a point for decreasing how much they sit by an hour. And we were very conservative with these cutoffs. And so when we do that for the adults and the children, what we see is an improvement in both groups. Again, no difference between the two, for both the adults and the kids. So then we decided to look further at this data. Well, what does this data really mean, right? Our groups aren't different. What does this mean? And so when we looked, we wanted to see, well, both of our groups got resources. What were the resources doing to how our families did, right? And so we found out that we asked at every point, we asked at baseline, we asked at 6 months, we asked them at 12 months, we would ask the families about what different resources they were using on our surveys. And so when we look back at them, we're able to see, well, if we take out the resources they were using at baseline, and then we look at 6 months and we look at 12 months and we see, are they using some sort of new resource that they weren't using before? 102 of 170 families that we had 6 and 12-month data or 12-month data on were using some sort of new resource that they didn't report at baseline. So that's about 60%. And so we were able to use that data and look. And when we look and we see, well, if you used any new resource at all, did you do differently? Were your outcomes different than those who didn't change at all, got no new resources? And we don't see a difference there. But when we focus in on those basic resources that we thought were going to be really important to people, things like housing and heating and financial resources, when we look at the people who had new basic resources, those types of resources, those people who got a new resource, those adults who got a new resource did better. And what we saw was an improvement in moderate to vigorous physical activity among those people who got those new basic resources by about 20 minutes a day among the adults. And we saw some changes that don't reach what we would call statistical significance, but are going in the right direction and are very close. In a decrease in the adult BMI, in adults BMI by 1.2 kilogram per meter squared. So that's that weight over height squared. Okay. And then, and a small increase in their fruit and vegetable servings. So that we thought that was really interesting, and it fits with the idea that we think that basic resources have to be provided to these families before they can make changes. And maybe that's probably much more important than the health coaching that we were giving them. So what does this mean? What it means is that both the intervention and the education only group improved in the family nutrition and physical activity scale and our composite measure, meaning that we were seeing improvements in families in both groups, but no difference between them. So it seems that health coaching didn't really seem to make a big difference in this group, but I will say that there were some families that loved the health coaching, okay? And it also may be that the health coaching has other benefits that aren't included in the outcomes that we were looking at. So what does this mean? It may mean, there are a couple of ways we can interpret this. We can interpret this as saying that providing resources and education really helped both groups. On the other hand, we could also interpret this as saying we've got a bunch of highly motivated families who joined our intervention and made improvements despite us. But if so, they did it exactly, they both did it in both groups. Or perhaps something else happened outside of the intervention that we don't know of that affected all of these families. Okay. We don't know of anything, but you never know, right? So those are the things, those are the possibilities. And so those are what we have to look into for the future to make sure that our assumption that resources are doing something is truly correct. So thinking forward, what we would like to do is to focus on providing resources and providing them better than we did. You guys all work in this field. You know how hard this is. You know better than I that getting people connected with resources in a complicated system as we have, where every different non-for-profit is working so hard on a shoestring to provide them, that this can be a challenging intervention, and it can be a challenging thing for families to navigate. So we want to be able to do that better. And then we'd really like to see what happens compared to just families who we give a delayed intervention, resource intervention. What does that look like in terms of behavior change? And because if that was positive, that would really bolster this. I suggest that resources are really the key to helping this group. And it's not something that maybe isn't intuitive, right? But sometimes we have to prove it to get funders and other people to listen. And it comes back to this idea that we tried to do this simultaneously. We knew that providing resources to these families was going to be important for them to be able to make changes. But it's very hard, but we only had 5 years, total to do this. And so we really tried to do them at the same time. We tried to give them connect them to resources and get them going with health coaching at the same time. And it may be that what's most important is to really address these basic resources first, to get families stabilized and in a good place where they actually have the bandwidth to even think about anything else before we do anything else. And then maybe once families are in that place, they might really enjoy health coaching. They might get an additional benefit from health coaching. But it's hard to think about health coaching or even using motivational interviewing when you're worried about your rent check. So these are a lot of my community partners who I could not have done without them. They are really the drivers of this research. I really enjoy working with them. And so I'm going to stop here for 1 second and see if there are any questions.
Dr. Laroche, thank you for an outstanding presentation. If anyone has any questions, please feel free to unmute yourself, or if you'd rather just post it in the chat, we can share it that way as well. I do want to recognize the partnerships and the people that are on this call with us today. We have a number of partners from organizations similar to what you're mentioning from your project work in Iowa. And so one question I have for you is, what are your plans for bringing this sort of effort to Kansas City? And what can those of us who are on the call here with you today, what can we offer that would be of value?
Yeah, so I would love to bring this sort of effort to Kansas City. What would help me most is to hear from you all, to hear from what's going on in Kansas City. What are your needs? What sort of things are you doing now that I might be able to help you with? I'd really looking in part to think about trying this bigger trial that I was talking about, but I'm also thinking about, where are those natural experiments? Where are you guys already doing great things to help families get resources? But how can we look at those and use those opportunities to evaluate what you're doing and to look at something unique, to look at if I'm providing housing to families through a program, am I also having other effects? What effect can we look at, eating and physical activity and those things that we don't always look at when we're thinking about housing, to look at, are those changes happening as well? Or are there other questions that you really need to know to improve what you're doing, but we know that funding often comes with very little money for evaluation. They want evaluation, but they tend not to give you very much money to do it. And so that is another place where I can sometimes help by finding money for evaluation and helping you do it if you need that assistance. Anything else?
So, yes, well, so I have a number of other questions that I can keep this conversation going with. We did have something come up in the chat, but before I get to that, I did want to ask a little bit. I know we have some partners from the YMCA. We have partners that support early care and education centers, lots of health department partners. So I wanted to talk a little bit about health coaching and the qualifications of people that you had do the health coaching. You know, what does that look like? What does it look like for our partners? Who's offering that? And what sort of skills or expertise did your health coaches have for this project?
Yeah, so our health coaches, you can see some of them in that picture there. We hired them from the community. Most of our health coaches had college degrees of some sort, but more importantly, they had a history of working with families, and a history with working with families with fewer resources. And what we did was we trained them. There is a group at University of Iowa who we have people who are trainers in motivational interviewing. And so they spent time training our health coaches specifically in motivational interviewing. They went through a couple days of training, and then what they did was they did practice sessions and had which were taped, and then they went through those with our health coach trainers. And then as they did their first few ones with families, we taped all the sessions with families if the families were okay with that, and used them to continually train our trainers or health coaches. They would listen to selected ones with their trainer to go through and say, yeah, that worked really well. No, that didn't work so well. This, and we were trying very hard to make sure they were doing very pure motivational interviewing. We have found that you can get a lot of good benefit even if you're not a perfect motivational interviewer. If you have the right spirit, that can be good enough. So so our health coaches were pretty well trained, but I know that at least the one in Des Moines, had done some motivational interviewing training with their health coaches. And so there's a lot of different opportunities to do that sort of training with people, but it certainly does not require being any sort of healthcare sort of person. In fact, healthcare people are terrible. We're too rigid. Community people are better.
Okay, well, that made me chuckle. It sounds like one of the key things about the health coaches that you used was really knowing the audience, being familiar with the community they were serving, and the that sort of thing, versus their background knowledge about health behavior.
Exactly. Honestly, the basics of health behavior are not super complicated. Soda and things like that. So those sorts of things we can teach people the basics.
And the motivational interviewing is about getting people to identify the change they want to make versus telling people the change they need to make.
Exactly.
Okay.
Absolutely.
I did want to ask, there's a question that came in through the chat, asking, have you considered early childhood partners? I wonder about if home visiting and Head Start might be places where families are connecting to resources and doing motivational interviewing with family advocates/educators.
I would love to work with early childhood resources. We had additionally, the reason that what we did was structured with 6 to 12-year-olds is because the idea then had been to include the kids, and it's hard to include a 4-year-old. I think there's absolutely, the sooner we can help families, the better. And the younger the kids are, the earlier we can get them, I think is fabulous. So I think there's a lot of room for working in early childcare, and it is totally something that interests me.
That's great. There are a lot of early care and education trainers and maybe I think a few providers that are on the call this morning. So for those of you who might be interested in getting a little bit more information, I will invite you to share that on the evaluation at the end of the program. I would also invite you to email us directly at weighingin@cmh.edu. Here's another question that just came in. You mentioned that basic needs like rent need to be met first. Is the CDC's recent moratorium on rent collection a potential natural experiment for further research?
That's a good idea, actually. That's really, it's not, obviously not a permanent fix, but whether that had some benefits is a good question, actually. That's something I'll have to think about. I can tell you that one of the things that we did, well, one of the other projects that I have on here that I can show you quickly if you want is looking at food pantries. And one of the things that we were interested in was looking at whether the moratorium on rent was affecting whether people needed to use the food pantry.
I think that'd be great for you to share that with us, because I did have a question about the fruit and vegetable boxes and what information you may have from your project about the use of the fruit and vegetable boxes. Did people like them? Was that
Mhm.
what impacted the slight increase I think you showed in fruit and vegetable consumption?
Fruits and vegetables. Yeah, the interesting thing was there was some fruit and vegetable increase in the group that didn't get the fruits and vegetable boxes too. So whether that's reporting, I don't know. The fruits and vegetable boxes were well received in general. People really liked them. In fact, we heard a lot about them in the interviews at the end. They were a challenge in that some people had trouble getting to the food pantry to get them, and we simply were not able to go all across the city and deliver them. I think that's what people really would have loved. If we could deliver like Amazon, that would be fabulous, right? So we sometimes had people who didn't pick up their food boxes, but people really did enjoy them. We tried to make sure it was a mixture, that there were fresh fruits and vegetables in every box, and then there were also usually canned, an assortment of canned things as well, so they had a mixture. So I can show you. How are we doing on time, Shelley? Do you want me to? What?
We have plenty of time.
Okay. Well, just for interest, let me show you this so I can. This is what happens when you're working with community partners and they have a question, right? An additional question. So we had a completely different plan with one of my community partners, and COVID hit, and completely it wasn't going to work anymore. So, but what happened is the Des Moines Area Religious Council, they supply food to 16 food pantries throughout Des Moines. And in January and February, and they had many individuals who are regularly picking up a food box every month. Okay, they have these monthly food boxes, and then you can go back for little things that are available daily, sort of thing. And then March, COVID hit, right? And we know that once COVID hit and once the economic impacts of that started hitting, that we were getting new families and individuals who needed food help. But what we didn't realize until my community partners started talking to me about it was that in April, May, and June, suddenly hundreds of families who accessed the food pantry regularly, who usually came every month, just stopped coming. And the question that the Des Moines Area Religious Council wanted to know was why? Why are these families not coming anymore? And so we kind of set out, and they had a lot of theories. So we set out to see if we could find out a little bit more about that, which turned out to be a little more challenging than we had hoped. So what did we do? Well, so the Des Moines Area Religious Council has a list of all the people who sign up for these food boxes. And so we made a list of the people who didn't come in, who came in January and February, but didn't come starting in April. And we mailed them all letters and said, you know, can you answer our survey? Very short. And if we can, we'll follow up by phone if you don't answer us. But it turns out that a lot of people we didn't have phone numbers for, or their phone numbers no longer worked. That's not surprising. And so our ability to follow up by phone turned out to be more limited than we had hoped, not to mention the fact that with the election year, nobody was answering their phone. But this is what we asked them. You know, we asked them about, you know, did you skip coming in April, May, and June? We knew they had, but we wanted to see what, you know, if our data was right. And then we asked them if they've skipped coming, why didn't they come? And then we asked them about whether they were planning on coming back and what we could do to make it easier for them to be able to get to the food pantry now with COVID and everything going on. Because our concern is that these people still need food and they're not being able to come to the food pantry. And so, as I told you, we only had phone numbers in for certain numbers, and only people weren't answering because of spam in the election. And then I don't know if any of you are aware, but there was this small windstorm that came through Iowa and knocked out large swaths of electricity and so forth right in the midst of our data collection. So this is just a very small sample. There are more coming in now. We've done another letter, sent out another batch of letters, but just to give you an idea of the sort of questions that can be asked or the sort of things that we're hearing. So what did we ask them? We asked them, well, I didn't go to the pantry because, and we gave them a whole list of ideas and a chance to write in something else. And what you'll see is, in terms of the people who did answer so far, we've got, I didn't go because I might catch the virus, right? That was a important one. And then also, I liked it better when I could use points to buy food, because it used to be more like a grocery store, but right now it's back to you get the box that you get, unfortunately, because of COVID, though they're switching back and finding ways to make it less of that again. I didn't come because I wanted to make sure enough people, because that's what the food bank was hearing a little bit, was that I wanted to make sure there was enough food for everybody else, which is really nice of these families. But we still want them to get food if they need it. We thought, well, the SNAP benefits went up, right? So maybe that was why people weren't coming. And there were definitely some people who said that their food stamps had gone up and they didn't need to come. A little bit from the unemployment check or the stimulus check, because we thought, well, now maybe people don't need it. And then, but I can tell you, here's the number one reason. People thought the food pantry was closed because of the virus. They just assumed the food pantry was closed. And we could see why that is, because the way they changed things and whatever, I mean, some people just assume that, but also, as we asked them, I thought the food pantry was closed because the parking lot looked so empty, because they changed how people could get their food. But this is, well, I'll have better data for you when the rest of these responses come in, but it's kind of an example of how these questions that I certainly wasn't on my radar can come up, and how we can sometimes turn around things to try and answer them. And at this point, a bunch of people have found that the pantry is open and returned, and then some of them aren't sure if they're coming back. but they will come back eventually. So we need to plan on these people coming back, which means that now the food pantry will have all the new people plus the people they had before. So they need to plan for that. So this is my family. Lots of pictures of my son. And what I want you to see down here in the corner, this is my email. So you can certainly email weighing in. They know how to find me, but if you prefer to just send me an email directly, that's my email, feel free. That's the end of that. I actually had a couple of questions for you guys.
Yeah, we do have a couple other things that came through the chat. So if you don't
Great.
mind, I'm going to go through those, and then I'd
Absolutely.
invite you to ask the group a question or questions as well. One question was, were the community resources provided by local, state, or federal government, or were they private, not-for-profit?
It was a mixture. We had we linked them. We basically had a really good list. The person we had doing our community resource screening was somebody who was doing that already as part of, she was an employee of one of our community partners. So she was already trained and knew how to do that and was doing that in a different capacity. So she was very familiar with the local, state and federal resources that people might be eligible for. So we did a combination, anything that would work. We had a list. She had an ongoing list.
Well, I love that idea of, it sounds like you were sort of spreading the work out. So you're partnering with those organizations who are already doing this, already have the knowledge, which, as we all know, helps you get farther faster.
Yeah, it allowed us to share resources,
Yeah.
because, you know, I didn't have to find and hire a whole new person.
Yeah.
And it helped them because I could help pay for part of one of their people with the grant.
Win-win.
Yep.
A couple of other comments. So one comment, extension of free lunch to all students and extension of SNAP benefits might be natural experiments, as well as the moratorium on rent.
Yes.
Another comment, I can attest to the benefit of motivational interviewing and behavior change with WIC clients. It takes some time to get in the habit, but benefits the client directly. There was a question about tracking that in WIC. So if there's an ability to track how often families access referrals provided. And I do know that's one of the challenges we have heard with work, especially in the healthcare setting, as you're being referred to resources, how do you get that information back that a family accessed that resource? Can you speak to that at all?
So that's a really challenging, We found it challenging, even with our community resource specialist. We thought that's how we would know how everybody did, but actually catching families and finding out exactly what happened all the time wasn't as easy as it sounds. So there are a lot of people trying to figure that out. There are some big kind of systems being tried out that link, you know, not-for-profits together and allow them each to put something into the system that says, yes, we met with so-and-so and did this, and that it's something that all the different organizations can access. But that is a huge undertaking. I know they're trying a little bit of that in St. Louis with they've got a COVID grant, and the people there they are trying that out. It's United Way has one, so they're trying a system. So I'm interested to see how that goes. But there are definitely people trying it, but it is not a small undertaking. And the balance is that we don't want to add extra work to all these organizations as well. You know, they're already putting data into their own system, so then they have to put the data in again into another system. But trying to link everybody's systems together is a Herculean undertaking.
Yeah.
So, because everybody's is different.
Yeah.
Some people are on paper.
Oh, which might make it even harder. So with that, I'll turn it back over to you to ask some questions of the group that you think would be helpful.
I think I covered some of these, but these were just the things that I wanted y'all to think about. You don't need to answer them right now, but things to think about, and at least, get in touch with me if there's some way that I can help. Are there ways that weighing in or I can help you or your organizations? Do you have programs that you'd like to evaluate better? Are there questions that you need answered, kind of like, DMARC had questions that would help you do what you do better? Are there interventions you wish you could do but need others to help? Can we get a group together? And are there issues that need addressing that you need help with and funding to get started? That's the other thing that I know how to do, and it's writing grants. And I know some of you are blessed with fabulous grant writers as well, but if I can help.
So I want to thank you once again for being willing to join us this morning, Dr. Laroche. And I know that even though we're at home, I want to encourage everyone to do what we have encouraged people to do when we're in person, and that is to stand up and give you a round of applause. So here's me doing that. Okay, so with that, we are going to move into the update part of our meeting today. So what I want to share is a reminder of our Fitastic at Home resources. I hope many of you are familiar with those and share them with the people that you serve. On our Fitastic website, that's Fitastic with 2 T's, fitastic.org. We've begun to include a variety of resources that are valuable for families and organizations related to physical activity, nutrition, family well-being, and unplugging. And we've already hit on a few of these things and why they're so important, especially during a pandemic and when people are at home or don't have that same access that they might have had before. So I'd encourage you all to go onto our website and take a look at those. We'll also invite you, if you have resources that you have either access to or have developed and they aren't included on here, please feel free to share those with us so we can include those on our website as well. The other part that you may or may not be aware of is we've started doing partner spotlights. These are conversations with our community partners talking about healthy lifestyle topics. We have new videos that sort of premiere right now. It's every other Tuesday at 9 a.m. We post them on our social media channels, Facebook, YouTube, Twitter. I want to thank all the partners who have been willing to join us in a conversation. Our next one is going to be Aubrey Neal, who's the dietitian in the Employee Wellness Center at Children's Mercy. She and I are having a conversation about eating during the holidays. If you have an idea about a topic or you're interested in being featured, please, again, contact us, weighing in at cmh.edu. We'd be happy to feature you and your organization as well. As you're doing that, I encourage you all to follow us on social media. We have Twitter, Instagram, Facebook, and YouTube. In fact, on our YouTube channel, that's where we'll be housing the recording from this meeting and other quarterly meetings. Now, I'd like to share an update about our work on the Kansas City Physical Activity Plan. So I'm going to turn it over to Dr. Shook to share where we are and some really exciting news related to the Physical Activity Plan.
Good morning, everybody. I hope everybody's doing well, getting ready for Christmas. I just want to say thanks once again to Dr. Laroche for that presentation today. It was a great presentation. She obviously does great work, and we are ecstatic that she is now part of Children's Mercy and the Center for Children's Healthy Lifestyles. So We look forward to having her around and collaborating with her on lots of different projects, and hopefully you will as well. So as many of you know, we've been working on the Kansas City Physical Activity Plan for a little over a year now. I'll just briefly give an overview of what the plan is in case you're not familiar, or to refresh your memory, and then provide you an update with where we are in the completion of the plan. So the Kansas City Physical Activity Plan is modeled after the National Physical Activity Plan. And this is just a Kansas City focused version of that plan. And our goal is simple. We want to create a series of sector-based strategies and tactics and priorities that will ultimately foster a culture of physical activity in our region. And we really want to make a collective statement that physical activity is a public health priority in Kansas City and our region. We want to develop a multi-sector coalition to advocate for priorities. So it's not just Bike Walk KC that's doing this work. It's not just weighing in that's trying to get physical activity initiatives going. We want to have a multi-sector coalition to do this work. And we want to create a framework that allows implementation of strategies and tactics and action items. So basically, they are shelf-ready frameworks that any organization can pick up and move forward on their own. Additionally, we're working on kind of 3 overarching priorities. The first is to increase local funding for physical activity initiatives. The second is to develop or to complete a regular comprehensive surveillance of physical activity metrics. We created the first surveillance project earlier this summer, and that is the Kansas City Regional Report Card for Physical Activity. So if you haven't seen that, I'll show you where you can find that on our website in just a minute. That was number 3 there. And then we want to do this on a regular basis. We want to have regular surveillance of physical activity metrics. So, you know, is that once every 5 years? Is that once every 8 years? We don't really know, but we want to do it on a regular basis. So here are those sectors where we're developing our strategies and tactics. So we've got healthcare, early childhood, healthcare, early childhood, infrastructure, faith-based, healthy schools, parks and recreation. Those are the 6 that we concentrated on during year 1. During year 2, so starting right now, we're focusing on youth sports, public health, business, and media. And I'll show you how, if you want to be involved in one of those groups, how you can do so. But an important point is, even though for the first 6, infrastructure through parks and recreation on this screen, they really did a lot of their work in the first year, in this past year, but their work is not stopped. They are still having meetings. They are still refining strategies and priorities. And most importantly, they're really kind of working on implementation of their strategies and priorities that they developed during the first year. And so we had funding from the Kemper Foundation and HRSA Region 7 to do this work. We spent a lot of time over the past 13 and 14 months doing this work. In total, we've had 55 total meetings. So that's a lot, you know, almost 1 a week really is what we've been doing. We also had the Physical Activity Summit in September 2020. We had 115 attendees just at the summit. So that was a huge success. Overall, in the past 14 months, we've had 550 people participate in some form in our KC physical activity planning. And the exciting news is later this month, we will be releasing the Kansas City Physical Activity Playbook. And what the playbook is a representation of all the sector strategies and priorities that have been developed over the past 14 months. And I'll kind of show you what that looks like, but we've kind of developed a kind of a card-based system of sharing this information that we think is a really easy way to communicate the strategies and priorities that have been developed. We will ultimately print off this playbook and the cards, but we also know that most people will be using it through electronic versions and just by going to our website. So all of this information will be on kcphysicalactivityplan.org. The first full edition of the Kansas City Physical Activity Plan will be released in spring 2021. Now, that will include everything that's in the playbook, along with lots of other background information about all the meetings that we went or that we held, the decision-making process, all of those things. It'll be a lot of details, and so that's why it takes a little longer to develop. But the core of what we've been working on for the past 14 months will really reside in the playbook form that we're going to release later this month. As I mentioned, we're adding on 4 additional sectors in 2021. And so we will release a second edition of the physical activity plan and second edition of the playbook about a year from now, once the work of those 4 sectors has been completed. So here's what the playbook will look like. As you can see, we've got kind of a similar design element that we've been using for about the past 6 months with the physical activity plan work. And here's what those cards will look like. And we're making small edits to these, so they won't look exactly like this, but you can get the point. And on one side of the card, we'll have the strategy. And this just happens to be from the healthy school sector. So the strategy here is schools should implement the comprehensive school physical activity program. And then when you flip it over, the physical card anyway, on the other side, we'll have all the priorities that will support the strategy on the front side. And you can see in this case, there's 5 priorities that are associated with that strategy. In total, I think we're up to 19 strategies that have been developed over the 6 sectors. And the sectors are all organized by color. As you can see, there's orange and yellow and pink and green and purple and blue. Those all represent the different sectors that we have. And almost all the sectors have anywhere between 3 or 4 strategies that have been developed. And each strategy has about 3 to 5 priorities that are associated with them. So as you can see, there's a lot of content when you have all of these sectors, all of these strategies, all of these priorities. And so that's kind of why we think this playbook structure is going to be helpful as we communicate and as you communicate this information to other people. So for 2021, as I mentioned, we're adding the 4 remaining sectors in sports, business, mass media marketing, and public health. And if you're interested in joining one of these sectors, now is the time to email us. And there's our email address. You can also email one of us directly if you communicate, for example, with Emily Meisen-Sebelius on a regular basis for other things. You can just reach out to one of them individually, and we'll get you added to the email distribution list, and we'll let you know when we start having these meetings in 2021. As I mentioned, the playbook will be released in the next couple of weeks, and the first edition of the full plan will be released later in the spring. But most importantly, we want this plan to be an actionable document. And so we will also start implementing projects in 2021. And we've already submitted 3 grants with our partners to implement strategies and priorities already. And so we're really excited to actually start the work of implementing the Kansas City Physical Activity Plan. Another way that we can do it outside of specific projects is to advocate for priorities. And a great example of that is the Complete Streets Ordinance. And this was passed in Kansas City, Kansas, Wyandotte County. And we were happy that we could support, as Kansas City Physical Activity Plan, the adoption of this ordinance. And we were able to do that because it is explicitly outlined in the Kansas City Physical Activity Plan as something we want to accomplish. So this is exactly how we want the plan to be used. So as we release the playbook and you read it, if you see things that you want to implement, please just start doing the work. You can reach out to us if you want to, and we can support you in it or help you in it. But if you just want to take something and just run with it yourself, that is great as well. And so that's all I've got for our updates. Does anybody have any questions about the Kansas City Physical Activity Plan? I know there's lots of things in the chat box, but I haven't been keeping up. So, Shelley, if you see something, let me know.
Okay, I want to thank Emily and Matt for posting some both links and emails. So if anyone has any questions or comments or ideas or wants to join, again, feel free to let us know. There are also
Spanish versions. Yeah, so this is a great question. Spanish versions, we don't have Spanish versions available right now, but we do plan on submitting them for translation. However, it is a little bit out of our control because we don't control the translation. So I'm not sure of a timeline for that, but keep asking us and keep checking in on that. That's a great question.
What I'll add to that is if anyone has access to translations, sometimes that makes it go a little bit quicker for us. We've done that with some of our Fitastic resources. We partnered with organizations to do the initial translation and then had that translation adjusted slightly and modified and approved with our internal translation team. So if any of you have access to that, that can sometimes help this go a little bit faster. Again, great question. I do want to specifically call out Matt. I mentioned at the very beginning, he's our sort of technology support and design support. So I want to thank him for the great design work that he's done, both for the website, which you can see on here right now, as well as the cards and the playbook. He's been instrumental in that sort of design piece. So again, thank him very much for that. Okay, let me see if I can. You've already heard how to join a sector, so I'm just going to skip through that. We do have some additional time, so I would invite anyone on the call, if you have updates you would like to share with the entire group, I welcome you to do that right now. If you want to just unmute yourself, you can and share it with the group. So I'm going to pause for just a minute and see if there are any additional comments people want to share. I feel like I should be singing, or maybe we should, in honor of Alex Trebek this year, maybe we should have the Jeopardy time, the Jeopardy set music going on. Okay, so it doesn't sound like there are any other updates. So with that,
hey Shelley, if I could just say hello real quick, and
you bet, Rich.
Hey, it's good to see the weighing in crew and all the other folks. I wish it was in person. I know we all do. Hey, Dr. Shook and Shelley, great work, obviously, with the KCPA plan, and excited for the release of that first edition in March. Are we looking at any kind of large scale events to kind of bring the bigger group back together in 2021? Kind of another summit to kind of get everyone together and share that information and keep that energy going?
Great question. And Rich, I guess, first of all, I have a question for you. Do you play the role of Santa Claus in your house? You kind of
should.
have the,
I've got the weight down now and the beard, so it's all coming together.
So a great question about will we do another summit? And the answer is we don't know at the moment. We're still trying to sort out obviously funding and things like that. So hopefully we can do something. What the scale is of that event, we're not entirely certain. It would be great to do some sort of in-person event, because if possible, since we were not able to do that this year. So hopefully 2021 is an improvement over 2020 in some of these areas, and we can make something like that happen.
That sounds good, Dr. Shook, and just know that I think you guys do incredible work, and we want to be here to support you if there's another kind of event to bring that community together and share that energy. So please knock on the door.
Great. Thank you very much.
You bet we will. Thanks, Rich. And thank you to everyone who was able to join us this morning. We really appreciate you being here. We will, as I mentioned earlier, post this recording and the presentation on the Weighing In web pages, as well as on our YouTube channel. We'll have the link to the video recording. So with that, we're going to give you a half hour back to your day. Our next Weighing In quarterly meeting will be March 11th, 2021. Look for that information in your monthly newsletters. Don't forget to complete your evaluations. Thank you to Emily, who just posted a link in the chat. You can go ahead and complete the survey that way. We will also be sharing the survey link in a follow-up email to the group. So with that, I'm going to stand up again and give everyone a round of applause. Thank you all for joining us this morning, and have a great rest of your week. Have a great rest of 2021. Take care.